Time. Let's be honest, it's that time. All right. I'm hopeful that this will be sort of. Am I too loud now? This will be sort of an easy hour. A lot of this is going to be sort of repeat and kind of reframing stuff that we've already talked about, but hope to give you a couple new tidbits and give you a little bit of something to make it worth getting out of bed this morning. So, well, Dr. Johnson was enough to be worth getting out of bed this morning, but I want to, I kind of feel like you guys are paying a lot of money and putting a lot of time and effort into this, and I want to make every hour count if possible, and because I really want to show respect for you and your time and your effort. All right, let's talk about acute inflammation, and then I think next week we're going to talk about chronic inflammation and wound healing. And I think that will wrap up everything for the first, So, I don't want to say the T word. The first test. So hopefully this will kind of start to pull a few things together. So, acute inflammation is a complex biological response of vascular tissues. That's really important. It's vascular tissues that have blood vessels in them. And it's a response to a number of different harmful stimuli, whether it's physical trauma, chemical burns, thermal injury, irritants, pathogens, all kinds of things. So acute inflammation is a response of vascularized tissue. And so what is the purpose of acute inflammation? Well, get rid of the bad guys, dispose of any dead or dying tissue, sort of immobilize that injured area so that it has a best chance of healing, and then in addition to immobilizing, kind of compartmentalizing the area, so kind of making sure that you don't turn a mountain into a molehill into a mountain. So if you have a little injury, you don't want it to spread and make a big deal. So kind of compartmentalizing. Okay, so here's some of the cardinal signs, the really telling signs that you have an acute inflammatory event going on. Tag, there's another dog, and now I'm distracted. Where are all these dogs coming from? And why aren't they in here so I can pet them? Let's take 5 minutes and go into the dog, and then I can focus again. It's tough being an animal lover. Oh my gosh, can I tell you? Yesterday, if I just tell you a story, this is a tidbit of my life and why I always look tired. So it was about 4 o'clock yesterday, maybe 4:30 yesterday afternoon. My daughter called me and she said, "Oh my gosh, one of the horses got kicked in the face and his teeth are out of his head." And, and I thought, you gotta be kidding me. And, for herbivores, front teeth are kind of important, for like picking the grass and eating it. And this is her baby, this is her pride and joy. So I, raced home, talking to the vet the whole time. I have no idea what's going on, but I think it's really bad. And so I got home and kind of looked, and he didn't look like he was, suffering or anything, but he had this little snaggle tooth hanging out of the side of it. I mean, it looked like, wait, is anybody from West Virginia? Okay, all right. I'm not going to make a West Virginia joke then. Okay, how about Pulaski County? Anybody from Pulaski? Oh, okay, well, he looked like, he looked like he'd been on meth or something. How about that? Okay, nobody's on meth, right? Okay, that's the same joke. If anybody's on meth, I need to talk to you after this lecture. Okay. But he looked okay, and then the other thing is we only had 2 horses, and the other horse is he is well conditioned. Let's just say his butt is this big, and I thought, how is I don't think Trigger can get his back legs off the ground to kick Spartacus in the face, and so I was just having a hard time visualizing it because he does not he just sits and eats and he's very fat, so I was trying to figure out how that happened. Well, So, we had the emergency vet racing over, getting ready to cerclage and immobilize a broken jaw and, kind of think about, what we're going to do. And it turns out it was a baby tooth coming out, so it really wasn't such a big deal after all. But I think he had gotten it caught on something, and so it was kind of hanging out, and it had some gut, like soft tissue kind of stuck to it and whatever, but all is well. So, but that was it was quite an emotional ride home. Like, oh my gosh, what am I going to do? Am I going to have to do some oral surgery, or what are we going to do? Because he's fabulous. Anybody who's a horse person, he's a Frisian, so he is the Fabio. Do you guys know who Fabio is? Okay, yeah, he's got the long curly hair and the gorgeous tail, and he's got the fur on his feet. He is very fancy, and but he just he really looked like he was on drugs or something with his little tooth hanging out. But all is well. So that's a happy ending. But that is a typical day for me. That's when you have 26 acres and 4 dogs and 2 horses and a cat who is psycho and a pregnant daughter living with you, there is never a dull moment. So if I ever sort of just kind of space out and can't find my words, it's because I'm exhausted. Okay, now you heard about my day. Let's talk about acute inflammation. So we have these 5 cardinal signs of acute inflammation, and these are telling that there's some kind of injury, some kind of something going on. Redness, heat, swelling, pain, and loss of function. So let's talk about why we have those. So redness, heat, and swelling, those kind of all go together. So when you think about an injury, we kind of went through this a little bit when we were talking about the cells. You have an injury, you have a damage to the endothelium, right? And so you have, all those vasoactive amines, and you could probably list about 20 of them by now, because everything, causes vasodilation and acute inflammation. And so all of that, swelling, that plasma leaking out of the blood and into the tissues causing edema, that's what's causing, the swelling is the edema fluid. The heat is, your core body temperature is a little bit higher than your peripheral body temperature. And we talked about that with the skin. The skin is several degrees cooler because it makes it a little bit of an inhospitable environment for pathogens. So when you have a lot of that, plasma fluid coming from your core and kind of leaking out into your tissues, it kind of causes a little bit of heat. And, the redness is also, because of those vasoactive amines, those vasodilation going on. So that's what causes the heat. Oh, the heat is never higher than your core body temperature. So the heat is just kind of, approximating, close to core body temperature. Pain, and so we have some chemicals that are released that actually causes pain. So I'm not a freak, but a little bit of pain is good. So because that little bit of pain sort of alerts you to, there's a problem going on there. Let's kind of look at it and see what's going on. And this is really significant, like when you get out into practice, into your big person job, you will run into diabetic patients all the time. You're going to be doing, obesity, diabetes, heart disease, and addiction probably all day long. And so, when you're working with your diabetic patients, one of the complications, or a couple of the complications of diabetes, is you start to have microvascular complications. So the small blood vessels don't perfuse oxygen and nutrients as well as they did before. So you have poor blood supply to some of the peripheral tissues. And that's why a lot of diabetic patients end up losing toes. Yes, ma'am?
Is that the diabetic neuropathy?
Well, that's the other one. So, you have vascular, like small blood vessels don't perfuse as well. And then you also have problems with the nerves not being very sensitive. So that's diabetic neuropathy. And so, and that's exactly to my point, is So you have, poor blood supply, so impaired healing. And then you also can't feel pain. So if a diabetic person stubs their toe, if you and I stubbed our toes, we'd be, cussing up a storm and limping around and on the floor, in agony. Diabetic patients don't feel that, so they don't know that they just, broke their toe or, injured their toe. And then they might keep hurting it because they don't even know that it's hurt. And that's why, a lot of times diabetic patients end up losing, having digits amputated and things like that because of the poor blood supply and the poor nerve supply. So, to make a short story long, a little bit of pain is good because it kind of alerts you that there's a problem in that area that you have to kind of clean it up, maybe baby it a little bit and get it, back to health again. And you also often have loss of function. So, have you ever, I know you have, hit your funny bone? It's not funny, is it? It hurts like the dickens. What do? And you kind of grab it, and you kind of walk around and whimper a little bit, and, you kind of keep it, still for a minute until it starts to feel better. Well, that's typically what we do with an injury, too, is we kind of baby that area and, keep it still, and it doesn't really move as well until it starts to feel better. And that's a really good function because it kind of helps the body to kind of focus on that area for healing. Does that make sense? Okay. So, acute inflammation, non-specific responsive vascularized tissue, and it's really a protective response to injury. So it's trying to clean up the mess and then heal that area and get it as close to post-injury or pre-injury condition as possible. So what are the purposes of acute inflammation? Well, we got to stop the bleeding, so we're going to need those platelets, and we're also going to need some other stuff to stop the bleeding. We have to clean up the dead cells and any invading pathogens that came in, so the neutrophils and the macrophages are really going to come in handy. And then we're going to promote wound healing, so we're going to have those fibroblasts coming in and laying down new collagen, and then also new blood vessels growing back into the area, new nerves growing back into the area to kind of heal the tissue. So I keep saying that it's a response of vascularized tissue to injury. And it has to be vascularized because what's happening? Vasodilation and transmigration of innate immune cells out of the blood into the tissues and, and all that edema and everything that has to have blood vessels. What happens if an avascular tissue is damaged? Well, then it's going to have to rely on its vascular tissue neighbors to kind of, diffuse, immune cells and diffuse healing factors into the avascular area in order for healing to occur. And that takes a little bit more time, so avascular tissues tend to heal more slowly than vascular tissues. So an example of that, veterinarian, so I have to use an animal example. You guys have probably seen this all the time. You're going down the interstate, and you look over and you see a car or a truck that has a dog in the passenger seat. And what are they doing? They got their head out the window, and their ears are flapping back, and their gums are flapping, and they are just loving that fresh air and that breeze coming at them at 80 miles an hour. And, they love that almost as much as trees. And so, they're out there with their eyes wide open and looking at everything. But, sooner or later, a bug is going to come at their eyeball at 80 miles an hour and hit them in the eye. and boy, that hurts. The cornea, the lining of the covering of the eye, is an avascular tissue, and it has to be avascular, right? Because you're trying to see out of the cornea. You don't want to be looking around, blood vessels. So, in health, the cornea is an avascular tissue. So, if that poor dog gets hit by a bug or a piece of debris at 80 miles an hour, it could scratch or abrade the cornea. And that being an avascular tissue, it takes a while for the cornea to heal. And during that time, the cornea can kind of erode and then ulcerate, and it can get so bad to be a full thickness lesion that the dog could actually lose that eye. And so that's kind of a big deal. Kind of a human example of that is contact lenses. So, especially the extended wear contact lenses, if you get anybody who wears contact lenses, you will understand this. If you ever get like a hair or a piece of dust or something underneath your contact between your eyeball and your contact lens, doesn't it just feel like somebody is stabbing you in the eye and gouging out your eyeball? It hurts so bad. Well, that's actually puts you at risk of abrading, your cornea, scratching your cornea, which could put you in the same boat as that poor puppy that had the bug. And so that's why it's so important to kind of keep your contact lenses clean, and make sure you don't have, introduce any, dust or, hairs or pollen or anything that could kind of scratch your cornea and cause corneal abrasion. If you do have an injury to your cornea, one of the healing mechanisms is the blood vessels from the sclera, from the white part, starts to grow into your cornea to try desperately to fix that lesion. And so, like people that wear the extended wear contacts a little bit longer than they're supposed to or something, and it causes poor oxygenation of the cornea and, little micro abrasions to the cornea. Blood vessels start growing into the cornea, so it's making it avascular tissue, and it can really affect vision. And the unfortunate thing about that is once you start getting blood vessels growing into the cornea, it's kind of a one-way street. You can't really remove those blood vessels again. So it's good to take care of your eyes. Wow, that kind of went off the rails, didn't it? Okay. See why my daughter gets so annoyed in the morning? Like, I need to just stop my caffeine intake or something. This is ridiculous. Okay, so what are the stimuli for acute inflammation? Infectious causes, you get a trauma and you get, bacteria in there. So infectious causes, physical trauma, chemical burns, and then some other things, tissue necrosis, foreign bodies, or immune responses. So there are many different things that can start acute inflammatory process. And this is sort of the sequence of events, and we talked about this already, so this should look familiar. You get some kind of an injury, vasodilation from all those prostaglandins and histamine and the serotonin and all that stuff, complement proteins and everything. Vasodilation, which causes increased vascular permeability, and that kind of, causes the leakage of the plasma and leakage of exudate. So there's a new term. Have you heard exudate before? So exudate is plasma with additional proteins, fibrin, things like that, and inflammatory cells. So when you hear exudate, think inflammation. Okay? So, and then that causes, those innate immune cells from the exudate, from the edema fluid, to, marginate, grab onto those adhesion molecules made by the endothelial cells, kind of roll and bump along the margin, adhere, tightly adhere to the endothelial cells. Then they pancake and transmigrate or diapedese out of the blood and into the tissues. And then they continue following those chemotactic signals, like some of the complement proteins that we talked about yesterday, chemotactic signals. And then, the innate immune cells get to the pathogen, and remember when they bind onto the passive pathogen, remember they increase their oxygen consumption, so they have a respiratory burst and increase their oxygen, so they get activated, they release their granules, they phagocytose, and they do all of that. And then eventually, they kind of make their mess, and the macrophages come and clean it up, and then you have sort of a resolution, things are kind of cleaned up, and then the inflammatory response kind of, winds down a little bit. And then, in the end, ideally you have resolution, and there's wound healing, and then you get to a point where you can't even tell there was an injury. That's ideal. A little bit less ideal is, maybe the wound was so big or difficult that you can't get normal tissue healed back in there. So the body just slaps a scar on there, just, a bunch of connective tissue, a bunch of collagen on there. And that's better than nothing, because at least it kind of, reestablishes some sort of a natural barrier to prevent pathogens from getting in again. Worst case scenario is chronic inflammation, where you just can't get on top of it, and chronic inflammation is bad, and we'll talk about that next week. Okay, so acute inflammation. So it's a complex biological process of vascularized tissues, and we have neurologic events, we have hemodynamic events, and we have cellular events, and they're all kind of happening simultaneously. So it's kind of it's a lot going on right after that injury. Okay, So, last night you got home and you're opening up your mail. I bet at least a few of you opened up the mail a little bit too quickly and got a paper cut. So have you ever gotten a paper cut and it hurts like the dickens? You wouldn't think a little cut like that, but it really hurts. And you look down like, ow! You look down and it's not bleeding. You think, oh my gosh, I am such a wuss. Like I thought that was worse, but it's not even bleeding. So you go and look at your bill and, oh my gosh, I spent that much, and then you look down 30 seconds later, it's gushing blood. Has that ever happened to you before? And so that is a part of acute inflammation. So when you get that initial injury, you have this neurological event where you have this initial vasoconstriction, and it's kind of just that initial attempt to stop the blood loss. But then all those vasoactive amines, from the mast cells and the endothelial cells and the complement and everything start causing vasodilation. So you get that initial, that transient vasoconstriction for about 30 seconds, and then the vasodilation happens, and then the bleeding starts. Okay, and so we have the bleeding, and like we said before, the bleeding is important because just that little bit of blood kind of starts to wash out a few of the pathogens, just kind of gets a few of the pathogens out of that area, which is good. And then also, it starts to bring in the oxygen and the healing factors and all of the innate immune cells to the area to kind of help with inflammation and wound healing. And so, but then in the meantime, while we're, bleeding and having all this stuff going on, we do have to kind of keep in mind that we have to stop the bleeding eventually. And so, remember those platelets, those little, cytoplasmic remnants of the megakaryocytes from the bone marrow. They come in and they stick to that exposed underlying collagen, that basement membrane that's underneath those damaged endothelial cells and kind of peeled off. So those platelets kind of form a primary hemostatic plug. So they're kind of just like a temporary band-aid onto that injured area to kind of slow down the healing. And remember, platelets also release some growth factors and things like that, so they can actually kind of help with the healing process too. But their main job is to kind of stick to that injured area, to that underlying collagen, and kind of form a primary hemostatic plug. Then there's actually, this is kind of going a little off, topic, but there's also a secondary hemostatic plug where soluble fibrinogen, it's a protein in the blood, soluble fibrinogen comes to the area and gets activated and ends up forming solid, like fibrin strands. So it goes from soluble fibrinogen to solid fibrin, and you get these strands of fibrin that kind of, lay over that primary hemostatic plug made by the platelets. And that fibrin is kind of like a scaffold so that other cells can kind of stick to it, and that's what makes a scab, right? And then as wound healing occurs, then the scab just kind of gets lifted off and comes off. Okay, good. Okay, so we have hemostasis taken care of, then that vasodilation, we talked about this, the blood vessels dilate, and so one thing it does is it kind of stretches those endothelial cells apart, so those tight junctions that are between the endothelial cells kind of stretch, and they allow some of the innate immune cells to sneak in between and get out into the tissue to do their work. But that vasodilation also causes the blood to kind of slow down a little bit. So, if you have a little tiny pipe, and the blood is kind of shooting out, 90 miles an hour, but if you increase the diameter, then the velocity of the flow really slows down, and that's really helpful because it helps the neutrophils to be able to adhere and then transmigrate out. So it kind of helps to, that slower blood flow kind of helps the neutrophils to kind of get out of the tissue a little bit easier. Okay. So, again, that vasodilation is mainly in the capillaries and the postcapillary venules. That's where the vasoactive amines primarily work. And they deliver the inflammatory cells, they deliver proteins to the injured area to help with, complement, activation, and then healing. And then it, leads to, again, like slower blood flow and hemoconcentration. So if the plasma is leaking out, but the red blood cells are kind of staying in, the blood gets a little bit more thick and viscous, so it's hemoconcentrated. inside the blood vessel, and that also helps margination of the inflammatory cells. Does that make sense? Okay, so again, this is a lot of review, which is good, I think, because we're studying for the exam now. So again, there's mast cells everywhere on all the skin surfaces and all the, epithelium, the mucosal epithelium. Mast cells are there just waiting for their opportunity to granulate. So if there's an injury, mast cells degranulate, they release their vasoactive amines and help with that vasodilation too. And again, it usually happens in the capillary beds and post-capillary vanuoles. Get that vasodilation and leakage of exudate, and then the neutrophils can sneak out and kind of do their job. So we got the neutrophils showing up first, and they are phagocytic, and they do that respiratory burst, and they release their granules, and they release their nets, just like we've talked about, and they really kind of help to knock down the pathogens in the area. And again, I have on there magnify inflammation above the required level in injury. So they kind of get carried away sometimes, and when they're releasing their granules and all those digestive enzymes and reactive oxygen and everything and then they release their nets, they're kind of making a mess. They do a good job, but they kind of make a little bit of a mess in the meantime. So then the macrophages come a couple hours later, and they continue the work of the neutrophils and kind of clean up a lot of what the neutrophils did to make a mess. And then that really sets up the environment for wound healing. Okay, so we talked a little bit about the neutrophils. So they go from the passing lane, you're going a little bit too fast, down the middle of the blood vessel. When they start to see those adhesion molecules, so it's selectins, and then it's integrins after that. And so they start to do low affinity bindings, they marginate, and they kind of bump and roll and decelerate, and they transiently bind and let go, and they transiently bind and let go, and transiently bind and let go, and each time they get slower and slower and slower until they come to a complete stop, and then they do high affinity binding with the integrin, and then they can pavement, flatten out like a pancake and squeeze out and go and do their work. Clinical note, leukocyte adhesion deficiency. You can have a genetic deficiency of these adhesion molecules, and then the neutrophils have a hard time getting out of the blood into the tissue, so you have infections that are poorly resolved in leukocyte adhesion deficiency. A lot of times with this, one of the first things you see, in addition to recurrent bacterial infections without formation of pus, and that's one thing you see. But then if you take a blood sample, you see a lot of hypersegmented neutrophils in those conditions because the leukocytes can't get out. They're just kind of stuck in the blood, and they die of old age in the blood because they can't get out and do their job. Okay. So neutrophils. So we talk. Has anybody talked about neutrophils as PMNs? So it's another one of those things where you have five different names for the same thing. I usually call them neutrophils. Some people call them polymorphonuclear leukocytes or PMNs. I like neutrophil, but I just wanted to make sure that I put that out there. So if you've heard PMNs, it's a neutrophil. It's the same thing. Okay. So they undergo degranulation, like we talked about with the reactive oxygen species and some other things. They can produce prostaglandins and thromboxanes, leukotrienes, lipoxins, and they kind of promote the inflammation. And they secrete pro-inflammatory cytokines. So they do a whole lot of stuff to kind of accelerate the inflammatory process. So they can recognize pathogens. Remember, the neutrophils have a whole lot of different toll-like receptors on their cell surface, and so they can recognize, E. coli, and they can recognize things with flagella on them, and they can recognize endotoxin, and they can recognize all kinds of different things because they have all those different toll-like receptors on their cell surface. And that helps them to not be picky eaters. That helps them to be able to respond to just about any pathogen that they run into, which is really helpful. Engulf, they degrade by digestion, and then they also upregulate inflammation. Okay, so there are over 180 chemical mediators that happen in acute inflammation, and I want you to memorize all of them for the test. No, just kidding. So they come from the plasma, from cells, from injured cells, from immune cells, and they usually kind of start a cascade of events, and they usually have specific targets. One other thing about acute inflammatory mediators is they upregulate really quickly, and then they're really short-lived, because you don't want inflammation going on long-term. Chronic inflammation is bad, so they usually are released really quickly, and then they have a short half-life, and then they're gone before you know it. So that's really helpful. So here's a few of the inflammatory mediators, kind of the classes or some of the main ones that we've talked about: histamine, serotonin, bradykinins. So those are the ones that are involved in pain. So they're made in the liver and they're present in the blood, and they kind of help to incite that pain that's really necessary to show the person that they have an alley. And they also activate prostaglandins. Okay, and prostaglandins, we talked about that: pain, fever, clotting. And prostaglandins are actually one of the targets of non-steroidal drugs like Motrin, Aleve, Advil, those kind of things, and corticosteroids. Complement, we talked about complement and how it helps with opsonization, it helps with chemotaxis and inflammation, and then also with poking holes in some of the bad guys. Free radicals, we talked about free radicals, nitric oxide and some of those reactive oxygen species yesterday. Some of the other ones, platelet activating factor, clotting factors that we talked about, and lysozymes, which are digestive enzymes. Okay, good. Okay, and then there's some other proteins involved in inflammation. Some of these might sound familiar to you. Like I said at the beginning, the body tries to not make a mountain out of a molehill. So if you have a little cut, you kind of want to keep it little. You don't want it to get too big. But sometimes it is big, and if it is a big injury that more than just a little thing, but kind of a big thing, then the whole body kind of gets involved. And one thing that happens is the liver starts to make proteins called acute phase proteins. And I think we talked about that a little bit yesterday. But acute phase proteins produced primarily by the liver, and it's released when the neutrophils and the macrophages kind of give an indicator that this is kind of a big acute inflammatory event, and it's more of a systemic thing rather than just a localized thing. So what do acute phase proteins do? Well, some of the things that they do is they elevate body temperature a little bit. They kind of turn up the thermostat in the brain and elevate body temperature. Why do they do that? Well, if you have a 101, 102 fever, that makes it too warm for a lot of human pathogens to be able to survive. So kind of changes your set point of your body temperature, and the viruses and the bacteria don't really like 102, they like 98.6. So if you elevate the body temperature, it kind of discourages growth of the pathogens. And so that's why, a lot of times the doctors will say, maybe just, if as long as your fever isn't, 104, 105, and you're worried about cooking your brain, a little bit of fever is actually kind of good because it helps the body. It's a mechanism that the body uses to kind of fight off pathogens. So, it's not always good to, get your body temperature back down to normal. That's one of the mechanisms that the body uses to try to get rid of pathogens. Also, acute phase proteins increase blood pressure. And so what that does is that kind of increases the circulation of the blood to kind of help with the acute inflammation and wound healing and all of that. So increased blood pressure, you get blood out to those injured areas. It also decreases your appetite and causes somnolence or sleepiness. So, because it's trying to shunt all of the energy towards healing that wound. So those are some of the things that acute phase proteins do. And you can kind of imagine, like when you get a cold or the flu or something like that, these are some of the things that you feel. You get a fever, your blood pressure goes up, you just want to put the covers over your head, and you go to bed, you don't feel like eating, and you just want to sleep it off. And so those are those acute phase proteins. Interesting thing, I want to make sure I say this now because I might forget later. So the acute phase proteins are made by the liver, and an example of that is C-reactive protein. So you've probably, if you've had any shadowing experience or whatever, you've probably heard of C-reactive protein. That's one of the vital markers for acute inflammation. It's also the function of C-reactive protein is to help to promote complement activation. So while the liver is increasing the production of these acute phase proteins, the liver is also cognizant that you have to sort of balance. You don't want to have more and more and more proteins in the blood, because you have to kind of keep that osmotic pressure, some of those same, so if you increase the production of acute phase proteins, the liver is going to decrease the production of other proteins to kind of keep the total protein approximately equivalent, right? And so this main protein that is decreased in production by the liver in an acute phase response is albumin, albumin is the main carrier protein in the blood that kind of helps to, transport drugs and things around the body. It also kind of helps to keep the blood pressure, keeps the blood or the liquid in the blood. So if you're increasing acute phase proteins, your albumin concentration or albumin production by the liver kind of goes down a little bit. So sometimes people refer to that as a negative acute phase response when the albumin production goes down. It's a negative acute phase protein. Does that make sense? Okay. All right. Then we've got a lot more proteins involved in inflammation, and proteins that are produced by the immune cells. They're cytokines, so they're made by immune cells, and they do something. And they're, they help to promote communication and coordination from one cell to another. And, communication is really important because this is kind of a complex process. So these cytokines really help with communication between cells. So you can have three different, classes of cytokines. You can have autocrine reactions, and so that's where a cell produces a cytokine and it motivates itself. So that cytokine is produced by that cell, and then that cell has a receptor for that protein. And the protein is produced by that cell, goes right back to that same cell, binds to the receptor, and then it kind of self-motivates, right? That's autocrine. Paracrine is when it motivates its next door neighbor. And then endocrine is where the cell produces a cytokine, it gets into the blood or lymphatics, and it motivates somebody, far, far away. So those are the three different ways that cytokines can work. And, without going into too much detail, we have interleukins. Interleukins are cytokines that are produced by an immune cell, by a white cell, a leukocyte, that can influence the activity of another white cell or leukocyte, so interleukin. Interferons are produced by immune cells, and they kind of help to interfere with viral replication. So interferons, and they do other things too, but that's the main thing that they do. We talked about chemokines, so they're the ones that help to promote chemotaxis of inflammatory cells to the area, and then growth factors that stimulate cell growth for wound healing. Okay. So I got a couple gross pictures to show you because, we can handle it. We're healthcare providers, future healthcare providers. Okay, so acute inflammation can be watery, and that's called serous inflammation. It can be fibrinous, so if there's a lot of bleeding going on, then you have a lot of the platelets and then the fibrin production, so you can have fibrinous inflammation. You can have suppurative. So when neutrophils come to an area, remember we talked about the neutrophils come to the area, they're kind of short-lived, they phagocytose, they release their granules, they have myeloperoxidase, and so they make that kind of greenish, slimy kind of pus, and then they release their nets and they die in that area. So that's what pus is dead neutrophils and dead cellular debris. So some people call that purulent inflammation, purulent, or suppurative inflammation, and those all mean the same thing. Those all mean neutrophils died here. So suppurative or purulent inflammation, and then ulcerative inflammation. So you've probably heard of ulcers, but do you really know what ulcers are? Ulcers are when there's damage to an epithelial surface, either skin or mucous membranes, and the damage goes below the basement membrane. So there's erosion and damage through the epithelial layer, through that collagen basement membrane into the vascular tissue below. That's called an ulcer. Okay, here comes some pictures. So this is an example of serous inflammation. So it's a blister. So like watery serous inflammation. So it could be a burn. It could be, like chickenpox. It could be poison ivy. Stuff like that can cause watery or serous inflammation. Then this is an example of fibrinous inflammation. So these are like a clot kind of forming. So in a hemorrhagic inflammatory event, you've got a lot of fibrin production. So kind of like a scab happening. That's fibrinous inflammation. Okay, ready for a gross? All right. Whoa. Okay, pus. So that's purulent or suppurative inflammation. So this is a pocket of dead, dying neutrophils. There's probably a really, amazing bacterial infection going on in there. And they actually had to cut it to kind of drain that pus out and to kind of help with the healing process. So that's an example of purulent inflammation. And you can kind of maybe see, oh, by the way, I don't put pictures on my tests because I kind of feel like everything just looks pink and purple and black at this point. And I think, it took me years to kind of be able to look at, pictures, histo pictures, and kind of figure out what it was. So I will use descriptions. So if you understand what cells or tissues look like by words, by descriptions, you're good. I'm not going to put pictures on my test. But maybe you can kind of see like multi-lobe nuclei in there, and maybe some, pale staining granular cytoplasm. That's what pus looks like histologically. Then up in the upper right, that is not bacon. It looks like, and I've ruined bacon for you forever. That's actually a cross section of an ulcer, and this is a diabetic ulcer. This is what happens to diabetic patients because they have microvascular and neuropathic complications. So those are some of the types of inflammation. Okay, so just real quickly, we just have a few more slides. Big picture, what happens? Immediate vasoconstriction, then you have vasodilation, hemostasis, mast cell degranulation, margination of white blood cells, large-scale neutrophil response begins, and then you get that hemoconcentration. You might even get some ischemia. Ischemia is inadequate blood supply to the area. That's not good. Chemical mediators are, interacting and working with each other. You get some of those larger white blood cells, those larger leukocytes coming in, like macrophages coming in. The complement system gets going. So that's kind of what's happening sort of in the first, couple hours after an injury. Then hopefully, as the inflammation kind of, waxes and wanes and sort of, resolves, then, ideally you have resolution where there's little or no damage, the inflammation takes care of all the pathogens and cell debris, the normal tissue heals itself, and then eventually it looks like nothing ever happened and it's all just a distant memory. That's ideal. If you have a tissue that is, badly damaged, then it might be more of a scar. It also kind of depends on the type of tissue that was injured. So if you have a labile tissue, something that easily regenerates, like the epithelium of your esophagus, you chew up that Dorito and swallow it, and it rakes all the way down your, esophageal epithelium. That epithelium is going to regenerate really quickly, because that's what it does. That's what epithelium does. It regenerates really quickly. So that's called a labile tissue. It's going to regenerate just like nothing ever happened. An example of a stable, less labile tissue is bone. So if you break a bone, it's going to partially regenerate, but sometimes it doesn't go quite back to as strong as it was before the bone break, and so bone is, not quite as easily healed as epithelium. And then some tissues don't regenerate at all, and so if you, a lot of times if you have a big tear to the muscle, it's not going to regenerate. It's just going to scar, and then, then you haven't gotten back to the pre-injury form and function, and so it's not ideal. Okay, we're going to talk more about tissue repair next week when we get to wound healing, but basically the vascularized tissue has to have fibroblasts repair the connective tissue. We have to have new blood vessels growing in. We have to have new nerves growing in. The epithelium has to grow over, and we'll talk about the types of collagen when we get to wound healing. You have immature forms of collagen type 3, and then when you kind of remodel after the initial damage is kind of temporarily fixed, then that type 3 immature collagen is replaced with type 1 collagen, which is a lot stronger, and it cross-links and kind of makes a stronger heel to it. Okay. So this is just kind of setting up the stage for chronic inflammation. So we talked about acute inflammation, neutrophils, vasoactive amines, immediate onset, hopefully just duration of a few days, and then either healing or abscess formation, which is a connective tissue capsule around there, or chronic inflammation. Chronic inflammation is bad. It's mainly neutrophils. It doesn't get resolved, so you have continued damage, continued attempts to heal, continued attempts to repair, and it can lead to, weeks, months, years, a lifetime of inflammation, which is really bad. Okay. And so we'll talk about chronic inflammation, macrophages and lymphocytes, and just kind of this chronic inflammation. Usually chronic inflammation is because there's something in the wound that's difficult for the body to repair. So, if you get a thorn or a splinter stuck in your skin or in your foot or something, the body has a tough time, digesting that thorn or that piece of stick or whatever is in there. Or if you, have surgery and you don't get the sutures out in, 10 days or something like your doctors told you, you leave those sutures in too long, that can cause chronic inflammation because it's a foreign body that the body has trouble with trying to get rid of. So we'll talk all about chronic inflammation. It's pathologic, it's active inflammation, tissue destruction, tissue repair, and it can go on for weeks, months, years, decades. It can be caused by weird infections that are difficult for the immune system to take care of, toxic or irritating agents, or cellular responses, or some diseases cause chronic inflammation. And we'll get to all that later. Summary and the top 10. Almost got done in time. Questions about acute inflammation? See, a lot of that